Good afternoon, ladies and gentlemen. I'm here with Dr. David Cohen, and we're going to be talking about the recent talk that he gave about the direction of future stents. So nice to have you here, David.
Glad to be back.
Okay. I really enjoyed your talk. You described sort of the current technology that's available, sort of the future direction of the stents that are being developed. So in a nutshell, which is the way to go? You talked about durable polymer stents, biodegradable polymer stents, polymer-free stents, and even biodegradable scaffolds. So what do you think, in a nutshell, is the direction to go?
Well, I think today, we have all three of those devices which are currently available. I think they have different niches. Mm-hmm. I think that, first of all, we have very good drug-eluting stents with durable polymers. Mm-hmm. And things like the Xience and the Promus and the Resolute. Those are excellent devices, and they have come along, so far from what we had when we first started. So we have to recognize how the bar is very high. Mm-hmm. And each of the different devices that I discussed today has its own role. So the first one that I talked about was metallic stents with bioabsorbable polymers. And the idea of that is to get rid of, to get rid of the stimulus for neoatherosclerosis and hopefully some of the stimulus for some of the late events, because some of the late events, the late thrombotic events, the late restenosis events, seem to be almost allergic type reactions, type of immunological reactions to the polymer. Mm-hmm. So if the polymer will go away, you're left with a bare metal stent. Now, bare metal stents aren't completely immune from late events either. We actually have some literature on that, but they're the most benign, durable device that we have. So those devices actually have a lot of promise. They certainly, the ones that are available, that are already around today, like the Synergy stent that we have in the United States, have results that in trials out to 1 or 2 years are equally as good as our durable polymer stents. What hasn't been so clear, though, is whether when the polymer goes away at beyond 1 to 2 years, do we really get that reduction in late events that we're hoping to see? Mm-hmm. I think time will tell with that, but I don't think we don't sacrifice anything by going with the bioabsorbable polymers. At this point, they're just as good, and so there's at least a theoretical advantage to that. So I think that's one set of devices, which is a very good one. Mm-hmm. The second set of devices we talked about was polymer-free drug-eluting stents. Do you have those in
not
Korea? Neither do we. We just actually finished a trial in the United States that is meant to, if it's successful, allow us to have the BioFreedom stent in the United States. So BioFreedom is a really interesting concept. So it's a metallic stent that has sort of a nano etching on the surface of it. So it has all these microscopic little channels, and that holds the drug, and it releases the drug very, very gradually over time, like the polymers do in our drug-eluting stents, but there's no polymer at all. And so that was tested in a big randomized trial against a bare metal stent in patients at high bleeding risk. And that's a big problem. I don't know, I'm not sure how big a problem it is in Korea, but I can tell you in the United States it's a huge problem. Okay. Because we have increasing numbers of elderly patients over the age of 80. That just by itself is a high bleeding risk factor. We have patients on anticoagulants. All these patients are challenging to treat. So if we had a stent that we could confidently use that would suppress restenosis, but allow us to use only 1 month of dual antiplatelet therapy, that would be a terrific advance for those kind of patients. And that's exactly what this BioFreedom stent seems to do.
So do you think the difference between the BioFreedom stent and the current generation durable polymer stents in terms of the requirement for the DAPT duration is truly from the polymer?
Well, it's a good question, because there is some evidence that with even our durable polymer stents that we have today, that there is some suggestion that we can shorten the DAPT duration down to at least 3 months. Nobody has had the guts that I've seen to go 1 month with those devices. So what I would say is, it may be possible. It may be that we can do the same with current polymer-based drug-eluting stents. But this stent at least has shown that it can safely achieve that. Okay. Because it was tested in a trial with 1 month of DAPT. It significantly lowered the risk of death, MI, and stent thrombosis compared to a bare metal stent with 1 month of DAPT, and it also significantly reduced the risk of restenosis. So with this one, we can confidently say we can safely use 1 month of DAPT. Whether it might be possible to do that with a bioabsorbable polymer. It might be possible to do that with some of our less thrombogenic durable polymers, but they haven't been tested.
Yes, so we're going to need more data.
Yeah, I think so. Hopefully, maybe they'll I think once this stent is out there, maybe they will have the guts to take them on. There are several trials going on in the United States today. with several of the different stent design, the currently available stent designs with short DAPT, with 3 months of DAPT. And so I think every reduction in DAPT. I mean, it's when did you start doing interventions? You're young.
I don't know, 15 years ago.
Before drug-eluting stents or only after?
Before.
Before. So,
yes.
so you practiced in an era like I did, when DAPT was 1 month.
When I first started to learn, but when I was actually an operator, it was
all
after
drug-eluting
the
stents. Okay.
DS there.
Yeah. So I practiced the first 8 years or so of my career with bare metal stents and 1 month of DAPT, and that was nice. I mean, we actually, I don't know if you, you probably don't even remember this, but there actually was, before we had clopidogrel and we only had ticlopidine, we used to go 2 weeks of DAPT with bare metal stents. So you can do all kinds of things with bare metal stents. It would be nice to get back to that.
Okay.
So that's the second device is devices without polymers. Then the third one is one we talked about yesterday, and we're going to be talking about for a long time, which is the bioabsorbable scaffolds. Because they are so conceptually attractive. Everybody thinks amazing. And I think in Asia there is a cultural bias against permanent implants, right? I mean,
exactly.
Tell me a little about that actually, because you hear about it. I mean, people don't like to have surgery. They don't like to have implants. Is it?
I mean, it's part of the culture to sort of leave your body to nature.
Okay.
You don't want any artificial, intervention. So I'm sure that the concept is very attractive to Asians, and in particular in Korea, even now that the BVS is not available, we can't use it. But even sort of during the shady period where there was some controversy in Europe and in US, there was a lot of believers in Asia and in Korea.
And when patients would ask for it?
Some patients would ask for it.
Because it's interesting, because in the United States, I've never had a patient ask for it.
Oh, really?
I would put it in the patient. I would tell them, explain. I'd be very excited and explain about it. And they'd say like, okay. I mean, they were less enamored of it. But at any rate, it is it's a very, very attractive concept. Is the stent is there when it needs to be there to prevent abrupt closure, to avoid the early recoil, let the artery heal, just like a splint or a cast or something like that, and then go away. And it is a very attractive concept. The problem has been, and we've been able to develop these devices which do many of those things, but they haven't done it safely.
Sure.
Yeah, that's
so
been our
you
challenge.
agree, Absorb may be dead, but definitely the category still lives on.
I think the category lives on, but it has shown us it is not that. First of all, you can't just a product like this in the current era is not going to survive on hype.
Sure.
Right? It has to have data, it has to have good data for it. And it also shows us that these devices, they don't have to be safer than what we have now, but they have to be as safe. Because the benefits are small. The future, the devices we have already don't have that many late events. We don't have that many late problems. Sure. So you can't start very far behind. You'll never catch up. So you have to really start very close, and then then if 3 or 4 years, yes, it can help. I think it would be nice, based on what we've learned from Absorb, to have thinner struts, because that would presumably be less thrombogenic, and more rapid absorption, because then we don't have to be on dual antiplatelet therapy quite as long. So I think those things are desirable. I think we will get there, but I think it is a sobering testimony to the challenges in engineering a plastic stent.
And have you heard anything from Abbott about what their sort of direction is for the future of?
They say they're continuing. I mean, what I have heard is they are continuing to develop. They have a second generation device, which is about 100 microns.
Falcon, I think.
Yeah,
the name is Falcon.
I couldn't remember it myself.
Yeah.
But so they are continuing to develop that. But obviously, it's perhaps with a little less all in. I mean, I think Abbott made a
big commitment,
business decision that we were going to put all of our resources into this concept, this device, and they went all the way in there. And then, now that they have had to pull that back, they're a bit sobered, a little bit nervous about that. It's a lot of money to invest in a device that they couldn't sell very much. But again, I think they're still in the game. I think the question will be, now we have the devices that are available in Europe. There's 2 or 3 which are still available, but they've undergone none of them have had taken on the big clinical trials like Absorb did. Will any of them have the guts to do that? Will they? Because they're going to need to in order to establish themselves. Okay.
Changing gears from the bioabsorbable stents to the discussion between durable polymer versus the biodegradable polymer stents. Are you a believer in the superiority of the degradable polymer stents. There was a recent trial showed
Right.
Orsiro was superior to the Xience, which has been sort of the
It was a gold standard.
It's
Yeah,
the gold
no, it
standard
was.
of all intervention trials. So
I mean, I was impressed with that trial. That's I've forgotten the name of the trial already, but it was presented at the ESC.
Yeah.
A very nice, kind of all more comers type of trial. What I will say there is that trial doesn't convince me of the benefits, and the reason for it was discussed pretty extensively at the time. Is that was a 1-year endpoint. The benefits of the bioresorbable polymer should be manifest beyond 1 year, because that's about when it resorbs. So I think the benefits we saw with the Orsiro trial have to do with how thin the strut is, right? That 60 micron
Sure.
stent strut
Sure.
compared to about 80 microns. I mean, thin is better.
Yeah.
So I think we will, time will tell if it starts ahead now, so it's got a good head start. I hope it works.
the thinner the better. I
Yeah,
guess.
exactly. I think
Just
so.
like
Just
LDL, the lower
exactly.
the better.
Lower the better, exactly. You can never be
thinner the
too
better.
thin or too rich, or that's what they say, right?
Okay. So, I mean, because of time limitation, I think I have to go down to the last question that I wanted to ask you, and that's what would a sort of an ideal or a perfect stent or a scaffold look like to you?
Well, a perfect scaffold would have the delivery and the mechanical properties of metallic stents, because those are outstanding already at this point, and would go away. I think and would only require maybe 3 to 6 months at most of dual antiplatelet therapy. I have to be realistic. I mean, I can ask for 1 month, but I don't know if you can deliver all those things. But I think a metallic performing stent that can, that is thin strutted, can get around all the kind of bends, all those sort of things, and goes away over 1 to 2 years, sounds good to me.
So it's been great talking to you, David. Thank you for coming all the way from the US to Seoul and your contribution to our society and our conference. Thank you so much.
Oh, it's my pleasure. Thank you.